All right, so I have disclosures. I do speaking for the following companies. For that reason, I'm biased. And for that reason, I am biased. You know, their execs call me up and say, don't say that, don't say this kind of stuff. So I declare that. It'll be important here because we're going to be recommending equipment changes. So that's going to be front and center for sure. So at a certain level, don't you think this is ridiculous? To bring somebody from out of town to talk to you about vascular access. I mean, you do this every day, you're a trauma center, you know? But in reality, it'll be something like this.
Gentlemen, you are the top 1% of all naval aviators. The elite, best of the best. We'll make you better.
All right, so philosophy of practice. That's another thing that we're going to be addressing here, the philosophy of practice. So my philosophy, everybody has a philosophy of practice. Mine is just at the front of my brain. And it's honed by these two guys. This guy is the chief of critical care and Department of Anesthesia at the Methodist Hospital in Houston, Texas, one of the palaces of modern medicine. And he says we have to make it easy to do the right thing and hard to do the wrong thing. In other words, if I put a line in ICU and 3 nurses have to come behind me to stand on their heads to change the dressing, I didn't do it right. Dr. Pittarudi from Rome puts it like this. We have to do what's right for the patient, not what's convenient for us. And if this means changing our technique, we'll change our technique because it's got to be for the patient, it's got to be for the nursing staff. So, what is a central venous catheter? Basically, a central venous catheter is a device which has its tip terminating in a central position down near the cavo-atrial junction. So this is what it looks like in anatomic dissection. And here, if you're coming up from the femoral, that it's up in the inferior vena cava. That makes it a central line. If you ask what are the central veins, that's a much harder question. It's much harder to define what is a central vein. But a central venous catheter has its catheter tip in the inferior vena cava or the superior vena cava, and hopefully close to the cava. Central venous catheters.
Are you a good witch or a bad witch?
Somehow, you know, it's gotten lost. You know, these catheters do good things. That's gotten lost to the infection, the complications. But you know, try to manage some of these COVID patients without a central line. Be my guest. So I mean, the pendulum's just swinging too far. Like, hey, these things do good things. Sure, there's a downside, and we're going to try to manage it, but we have to remember that central venous catheters do good things. But something went wrong in this country. People that went to, known medical schools, genius level people that go to medical school are doing something like this. And I want you to trust me on this one. You're not allowed to put a dressing on the corner of a patient's mouth and think that you're preventing an infection. It doesn't work that way. So if I walk through your intensive care unit and I see something like this, my conclusion would be that your process is broken. Okay? So then I ask the question, and I would like a little interaction. It makes it easier for me. Why do physicians do this? And it's multifactorial, but tell me, why do you think doctors do this? The big one, it's how they were trained. And that's a big hurdle. But the training goes back to the year 1969. Like if you practice anesthesia like it's 1969, you'd be out of date, So, fear. Fear of what? Fear of pneumothorax. So they're putting it up, they think they're getting away from the lung, but then they're making a mess and the nurses can't handle it and it leads to an increased risk of infection. I was in New York City and one of the infection prevention nurses was auditing the course, and she said, Dr. O'Dunn, our doctor said it has to be done this way. See, like, once somebody says that, they're closed-minded. Oh, if it has to be done that way, then we have to do it. But I'm going like, I don't teach that way, I don't show that way, So basically, we want the jugular catheters to look like this and to look like this, rather than like having it directed up toward the ear with a dressing near the mandible or the hairline, So essentially, it's a choice. So you can either tolerate the ones on the left side of the screen or you can fix it. And essentially that's why I'm here, that we can do this differently and it makes it better for the nursing staff. So is the fear of pneumothorax rational? So I want to compare pneumothorax versus CLABSI. And basically these are the things that we're going to look at: morbidity, mortality, extend the length of stay, the scarlet letter, this kind of stuff. Morbidity for pneumothorax is really minimal. I mean, it should be minimal. You recognize it, you either watch it or you put in a decompression tube or something. The morbidity for CLABSI is extreme. It's so extreme, we don't even talk about it because of the mortality thing. But like hip, like cardiac valves, hip replacements, that get infected, from this stuff. It's really a tragedy, the morbidity, right? The mortality for pneumothorax should approach zero. I understand in a hospital like this, once a year you have a tragedy. I get it. I've been in those hospitals. I trained in the New York City hospitals. You get a bad event with a pneumothorax once a year, twice a year. But the mortality for CLABSI is 12 to 25%. So the rationality, that's what we're supposed to be scared of, not the pneumothorax thing, right? Extend the length of stay. In some of the papers I read, pneumothorax extends your length of stay by 4 days. CLABSI by 12 days. You know what I mean? So the fear isn't well placed, So it's the cost. Pneumothorax expensive. You got to go to a nasty surgeon, and he puts in a chest tube, and he sends a big bill, all that kind of stuff, right? But for CLABSI, it's very expensive. I've seen $20,000 to $120,000, and we usually pick a median of around $50,000 for one of these things. Before 2008, you'd get paid. The government would pay you for it, but since 2008 decided, they didn't come in with that infection, you don't get paid for it, So then prevention or treatment of pneumothorax is really pretty straightforward. If you can do this, you're not going to get a pneumothorax.
Needle coming.
If you can follow your needle through the tissue down to the target, you are not going to get a pneumothorax. But preventing CLABSI is complex. The nurse violates that line 25 times a day. She's got to scrub the hub. She's got to let it dry. She's got to change the tubing. The dressing's got to be intact. There's a million things that you got to do to make to prevent a CLABSI. Then there's the scarlet letter. You know what I mean? If I caused a pneumothorax in Baltimore, my friends on the West Coast would know it. The word would be out. The whole world is out. So that's why people are scared of pneumothorax. It's attributable to you. But if you cause a CLABSI, no anesthesiologist in the world has ever accepted responsibility for a CLABSI because they send it out. They put it in and send it out. But if you cause a pneumothorax or an arterial puncture, there's no question where it came from. Suppose we could demonstrate a break in the process of CLABSI prevention. Would we fix it? Hopefully. I mean, that's why we're here, that if we can demonstrate where your process breaks down, that we can fix this thing. This is a consent form that I used. I put every vascular access procedure that the patient might need in there, and I put in there throughout the hospital stay. On the back, I listed all the complications. So basically, I got the consent one time. I didn't call the family at 2 a.m. I didn't withhold treatment because I didn't have it. So let me talk about the life cycle of the central venous catheter. The idea is to standardize our practice at each phase of the life cycle and standardize it at the highest level because we work on human beings. So the first phase is the assessment phase, vital. The second phase is pre-insertion, what you know is the insertion bundle. The third phase of this thing is the actual insertion of the device. The fourth phase is the dressing, care, and maintenance phase. And the fifth phase is the removal. Anything good or anything bad happens in one or more of those phases. And that's all there is to this thing. And that's all there'll ever be. That if you can decide where your process breaks down, you can deal with it. It's just at the end. If you get a bacteremia and you go, well, I don't know where it came from, you're not in a very good spot. But if you say, did we assess the patient for the right line? Great. Did we do the pre-insertion bundle? Did we put it in properly? You can see where things change. And another way to look at this is the chain of CLABSI prevention. And the chain is only as strong as its link. So each link, we're going to perform in standardized fashion at the highest level, right? So let's talk about the assessment phase a bit. The assessment phase is vital. You know what I mean? If you don't assess the patient for the right line, you're hoping to get lucky. And we'll show a case later where I think they didn't assess the patient for the right line, right? So this is covered by the MAGIC paper, vessel health and preservation, and other algorithms that'll help you standardize so that, you're looking over the patient and I'm looking over the patient. We kind of come to the same conclusions, right? This is the MAGIC paper. Annals of Internal Medicine 2015. I am one of the lesser authors of the MAGIC paper. Vineet Chopra, the newly minted chief of medicine at the University of Colorado, is on there, and Naomi O'Grady from the CDC guidelines. It's a big deal, a lot of, in uproar, very controversial. It's an assessment paper. This phase one, lasts from the time you arrive to do your consult until you do your hand hygiene, the assessment phase. And what do we look at in, say, the MAGIC document, other things are? Infusate compatibility. This is a big deal. I'll say a little more about that later. Are they difficult peripheral IV patients? Are they, more and more, I know you're seeing these difficult IV patients. If they're going to need 10 days of double antibiotics, don't start with a peripheral IV, How long are they going to need the line? Sometimes we don't know that, but that's helpful, to us to pick the right device if we have a projected duration for it. Do they have chronic kidney disease? That would lead us towards certain lines, and how many lumens do they need, right? So what can we do with this information? You can build MAGIC into your electronic medical record, and the MAGIC algorithms will help you pick the devices. It's a way to standardize so that we're all doing similar stuff, right? And they have a phone app, the Michigan MAGIC app. Make sure you put in Michigan or you get directed to a porn site. All right, so what are the goals for phase one, the assessment phase? The goals are, to figure out, does the patient really need central venous access? Really, the first goal, where this all starts, right? Then you decide which catheters are appropriate and which catheters are inappropriate. And the other part for this is to assess the veins for suitability, and that's what we're going to do in the simulation, something called the receiver protocol, rapid central venous assessment. So basically, there are good reasons to put in a central venous catheter, and there are bad reasons. Some of the good reasons are hemodynamic monitoring. Sure, you need a central line for that. TPN, definitely. Hemodialysis, you can't do it without a central line or some other way. Do they have peripherally incompatible meds? If the meds are too caustic for the peripheral veins, then they have to go centrally. And, multiple access in a critical illness patient, sure, no problem. But there are bad reasons to do it. And the bad reason is general access. And for myself, in my career, I put in many, many central lines for general access until we developed a strong nursing IV team and peripheral side. And then they were getting it. I was doing much less. It went down towards zero, how many lines I was putting in for general access. So basically, if you have one of these difficult peripheral IV patients, essentially you want to try to get an ultrasound-guided peripheral IV or a midline before you move to a central line just for general access. So that's generally the way we approach it, Talking about infusate compatibility a little bit. So this is a list, this is from the infusion therapy standards of practice that, these red ones are really pretty bad, pretty drastic. They should go centrally. The yellow ones, think about central. I don't know in this hospital if we have a list, but that'll be one of the things we do have a list of meds. Great. So, great. So we'll, that'll be a step forward. It comes into irritants and vesicants. If the chemical is really irritating to the veins, then you shouldn't give it. You should give it centrally where it's diluted. And if it's a vesicant where if it extravasates into the tissue and could cause damage, then you consider central for that. So basically it comes down to which meds can be safely administered by PIV, right? So, and which meds should go centrally. Now, if you see something like this, what do you write in your progress note? Somebody tell me what you would write in your progress note for that. That is extravasation of a vesicant medication. Now that's redundant because basically if extravasation implies that it was a vesicant medication, but that's what you would write in your progress note for that. And that's somebody that got dobutamine and epinephrine in the peripheral IV, like during the code. It progressed, so what do you call this? This is the same patient, that's like an eschar or a slough caused by giving the wrong medication peripherally, and this is kind of the damage that you can get from that. On the other side, the same thing, that it went on to having to be resected. So on the left side, the same thing. This is extravasation of a vesicant medication. It's like you can give these medications and you, quote, get away with it. But if the IV leaks, you're going to have tissue loss. And that's what we're trying to avoid. So you're avoiding the CLABSI by not giving him a central line, and now you have the plastic surgeon working on him for a bit. And this patient had calcium, which is an irritant medication, and he also had vancomycin, which is a little tough on the veins as well. So it led to extravasation of vesicant medication and loss of tissue. And one thing is, what is the failure rate of peripheral IVs in the United States of America? Anybody? 50%. So if you're going to give these medications, knowing that there's a 50% failure rate, and if the stuff gets out into the tissue, it's going to cause tissue loss, you have a problem. All right, dilution, of course, is the key. So this is a slide of the receiver protocol. 7 steps where we examine the neck and the chest, supraclavicular, and look for the sliding lung. And we're also going to get into the femoral, because we do the femoral outside of the groin. All right, good. Phase 1 assessment. Phase 2 is what I call pre-insertion, and what you know is the insertion bundle. So you want 0 CLABSIs, huh? Everybody wants 0 CLABSIs, but there are a couple of facts that we're inserting plastic tubes, inanimate objects, through the bacteria-laden skin directly into the bloodstream. We're doing this in immunocompromised patients that are actively infected. If you think that's a recipe for 0 infections, God bless you. I don't. And so we can't do anything about the fact that they're immunocompromised or they're actively infected when we get them. We can give them optimal vascular access, and that has to be our goal. So what do we know about central lines? The mortality of somebody with a central line is twice the general hospital population, and I hope it's because they're sicker, not just because we gave them a line. But that's the reality here. And this paper says that 65 to 70% are preventable. I like that number. Do you believe 100%? I believe infections can be prevented, but let's live in the real world. And the cost of eclampsia in this slide is $20,000 to $110,000. All right. So, pre-insertion. This is covered by the CDC guidelines, the Institute for Healthcare Improvement, and the Keystone Report, Dr. Peter Pronovost from Johns Hopkins, the lead author. This phase lasts from the time you do your hand hygiene until you drape the patient, okay? And the objective for this phase is infection prevention. That's what you're trying to do in phase 2. You're scrubbing the skin and all that, and we'll get into that. So it's infection prevention is the objective for phase 2. This is the paper that kind of solidified, the statistical validation of the stuff that we were doing. This stuff was recommended by the CDC, but this paper kind of solidified it. The intervention to decrease catheter-related bloodstream infections in the ICU, December 28, 2006. So basically what they did in this paper is they went to 100 ICUs in the state of Michigan, and they studied the patients for 6 months. They made their intervention, and they studied the patient for another 12 months. Stop and think about that. Think about doing that in New Jersey. Think about doing that in one ICU in this hospital for 18 months. It would be a big project. Now multiply it by 100. It's never going to be replicated, but this is why we read the paper. This is why we write, some articles and stuff. So what did they find? Before the intervention, there were 700 infections annually in the 100 ICUs in Michigan. Back then, it wasn't a bad number. That wasn't considered a bad number in 2006. But today, it's not a good number. We're not looking for 700 infections, right? So after the intervention, they found they were able to reduce their infection rate from 7.7 infections per 1,000 device days down to 1.4, a 5-fold decrement. This saved resources, it saved morbidity, and it saved lives. So talk about magic. How did Dr. Pronovost work this magic? What was the intervention that did this? So basically, we should do this, and there's no hospital today that has 7.7 per 1,000 line days. You'd be closed. You can't afford it. You don't get reimbursed for the care. There's no hospital, unless you're a critical access hospital in the mountains. No hospital has 7.7, right? So what was his intervention? And we all know it. The intervention was known as the insertion bundle. Hand hygiene, clexidine skin prep, maximal barrier precautions, daily review of necessity, and avoid the femoral site, right? So I usually say, how long does it take to do hand hygiene before you go in? It's like 30 seconds. You put on that alcohol foam stuff, you know? Chlorhexidine skin prep, how does that work? 30 seconds of back and forth friction prep, and while it's drying, you're setting up your tray. How long does it take an expert to get maximum barrier precautions on a patient? I say it takes about 30 seconds, 60 seconds. It's not a long period of time. Then daily review of necessity. You know, if you don't know the patient, you got to look through the chart. It might take 5 minutes. If you know the patient from the day before, it goes pretty quickly. And avoiding the femoral site, it takes exactly 0 seconds. So my point is, this is a 2-minute gig. Like, this is what's credited with reducing the infection rate 5-fold decrement if you do this. This is 2 minutes. You want to tell me it takes 5 minutes? No problem. There's a lot more to this than this 2-minute thing, right? And I was tasked to rewrite the insertion bundle. And my rewrite goes like this. I eliminate daily review of necessity because it's not an insertion practice. It's certainly a care and maintenance or a management practice, and nothing to do with the insertion. The insertion bundle's over once you drape the patient. And as far as avoiding the femoral site, I've changed it to avoiding the groin. And we'll get into that. We put catheters in the femoral all the time. One of the nurse practitioners in New Jersey is the lead on this, Matt Ostroff. You know, as long as you get it out of the groin, they work really fairly well. And this is what I'm talking about.
This is at roughly at the insertion.
So we're trying to get is see the femoral vein outside of the groin. We use micropuncture equipment always.
That was hard.
Go slow.
There it goes. I felt the fascia.
Beautiful. Great.
Got it.
Yeah.
There's a securement device. It's a permanent securement device.
Yep.
So,
Just follow that, man.
I'm just gonna come out.
There's definitely something I'd like to get introduced into this hospital going forward. We don't shave hair, we clip hair. All right, and this is me doing the insertion bundle. This is like, it takes me like 80 seconds basically to wash my hands, get on the chlorhexidine on the patient and drape the patient. It took me 80 seconds. I hope I get a 5-fold decrement in the infection rate because I did those 80 seconds properly.
So we call a closed gloving technique where your hands never appear until they're inside the glove. Okay, grab the jelly off of the bed, Martha. I don't want to drape it in there.
That's called closed gloving. You never expose your hand.
All right, would you come
and
in,
we'll demonstrate that.
Stand me up with you, please.
Want to say it again, what you want?
Yeah, that is.
Just relax.
And watch me avoid the femoral vein in this patient.
Yeah, fold it up.
Now, it's an important 80 seconds, don't get me wrong, but it's just 80 seconds in the life cycle of this thing, you know? Like, so how did we achieve such incredible results by just focusing on 2 minutes? There's only one conclusion that a reasonable person can draw from that, and that is the insertion practices prior to 2006 must have been pretty bad, because that you wouldn't have a 5-fold decrement. You might have a little bump if the insertion practices were good. But now, you know, everybody's doing this, so we have to look for other ways to improve things, you know? So, assessment phase, pre-insertion. We want to standardize what we're doing. This is standardized. What you're doing in Neptune is what I'm doing in Baltimore, is what they're doing in London. We're all doing the same thing at a high level because this is the way it is. When another disinfectant comes along that's better than chlorhexidine, we'll switch to it. But it's standardized. We want to standardize the first phase, the assessment, and the other phases, just like this is standardized. The national standard for insertion of one of these central venous access devices is the insertion bundle. Once you've satisfied the insertion bundle, you're good to go. Presently, that's a standard. It's not my standard, but that is the national standard. The insertion bundle has pros and cons to it. The pros are, it works. You know, if you look at that paper from Pronovost, there's this 5-fold decrement in the infection rate. It certainly works. It's standardized practice at a high level. That's what we're looking to do. We're all doing the same thing, right? But there are some cons to the insertion bundle. The insertion bundle stops at an inconvenient place, namely the insertion of the device. It doesn't tell you how to put in the device. It's like once you've draped that patient, you know, and because of that, insertion is not standardized. And then you'll get stuff like this. You see these are perfectly compliant with the insertion bundle. It doesn't talk about it. It doesn't say a word about the dressing being intact, where we put it, the exit site, right? And when I see this, I say to myself, where's the pride? Somebody went to medical school. You know what I mean? Somebody's a highly paid physician, and you just have to look at it, and it's wrong, you know? And we don't want the dressings to look like that. We want them to look like this. And that's standardized at a high level, and there's one question really, does it look like it's preventing an infection? To me, it does.